Hi, good evening, ma'am. Dr. Sengar, how are you, ma'am?
Hi, I'm good, Shubham. Hi.
Thank you, ma'am. Thank you for joining in, ma'am. So, the usual format is that we introduce you, and we used to have a quiz, but for this section, did not keep a quiz because I couldn't frame the questions appropriate to the paper. But I hope a lot of people should have gone through the paper. At least I have gone through, so I have a lot of questions regarding it. So I'm
Great.
sure you'll get them through the talk. But we'll start at 8:30, madam.
Yeah, sure.
Sure. And we record it, and it's there on the YouTube, so it stays later on also for any references if anybody wants.
Sure. Absolutely no issues. Yeah.
Thank you, madam. Thank you. So just give us another couple of minutes, and then we'll start.
Yeah.
Thank you, ma'am. हाँ मनीष नमस्ते बताओ Hi, a very warm welcome and good evening. Today it's Wednesday, 8:30, and it's the Cancer Academy time. And we are very, I'm very happy that we are continuing this thing on statistics, and we are able to get really good faculty to do this for us. And what we have seen in the past 4 months, that we have had three month-end lectures with Dr. Priya Ranganathan, who has been telling us the important aspects of medical statistics, and we are trying to club topics which go well together. And Dr. Priya had been very kind to actually suggest us what topics we could club in, the topics which go hand in hand. And we have had very interactive sessions with us. In fact, they have been the most interactive we have had with Dr. Priya ma'am. And we have come now to a point where it is almost a time to test ourselves. We have to look into ourselves, what we have learned, and this is what medical science is based upon. This is what we do when we read papers, we read published literature, we look into review articles, we look into RCTs, and the first thing, or the most important thing that we are asked sometimes in our exams also, is that if you were to critique a paper, how would you do it? And it's a very common topic in many international exams that we have. They give you it actually a 30-minute to go through a paper, and they ask you to critique it. So and this was also suggested by Priya ma'am, only that we culminate this medical statistics with a class like this. And we are very thankful to Dr. Manju Sengar that she agreed to do this topic for us. She actually sent a paper to us a week in advance, which I circulated, not a week in advance, but I circulated on Sunday, unfortunately. So I hope some of you have gone through it. It's not a very complicated study, actually, but it's a simple one. But it is the simple things which bring out the most common problems that we face. And I have gone through the paper. I'm sure Madam would have the paper included in her talk. We are not doing a quiz today because I felt that the quiz would dilute it, because I wanted to base the quiz on the paper itself. But I felt that if we could have it more interactive, we can ask more questions. It's a very fairly simple paper, but say paper which brought a lot of questions to my mind, and I'm sure you would have a lot of them for yourself. Uh, Dr. Priya has been kind enough to join us today also. She would be sort of moderating the session. She would also be answering a lot of statistical queries that we come across, and I'm sure it's going to be a very interesting lecture. So may I now invite Dr. Manju Sengar to open up her camera and mic and take on the session. The session, we have named it as How to Critique Published Literature. Madam, as all Tata people are, a great academician. She was the IRB in charge when I was there, and she would be the perfect person to scrutinize any not just paper, but actually a protocol also, to tell us how to get it right. So, Madam, the floor is yours, ma'am. Thank you so much, ma'am.
Thank you, Shubham. That was really kind introduction, and thank you, Dr. Geeta and the entire Max team for giving me this opportunity to interact with such an enthusiastic audience who's here midweek at 8:30 p.m. So thank you so much for that. And as Shubham has said, that Priya has already discussed so much, so I'm not sure whether my job is easier or tougher, because most people probably know more than me how to do the critical appraisal and how to look at the statistics of this paper. I'm going to turn off my video because at home I really have usually poor net connection, so I'm not sure whether because of video the thing should not drop off in between. So I'll just turn off the video. I'll share my just in case you can't see it. So
we can see it, madam. You just make it full screen, ma'am.
Yeah. Sorry. Yeah. So I hope it's
audible, madam. Ma'am, we just lost your audio. Sorry.
Yeah.
You're muted again.
Yeah. Is it am I audible?
You're audible, ma'am. Audible.
Great. So what I'm going to cover in next 35 to 40 minutes is the critical appraisal of the published papers. And if we just think about why do we read papers, except for that rare breed of people who just read sometimes abstract of the newly published article and flaunt their knowledge in the cafeteria, and probably when they meet or when they discuss with you in the meeting. Most of us read papers for two reasons. Few read because they want to write up a research proposal, they have a research question, and they want to understand regarding that research question what is already available in the literature, whether that question has already been answered, and if yes, what strength that evidence has, that whether they should conduct their research or they should not conduct their research, or whether they should modify their research question or make it methodologically more strong as compared to what is already published. So that's one reason of reading the articles regarding your own research question. However, not everyone does research. Still, we have to read papers. And the reason for that is that we want to practice what we call as evidence-based medicine. A lot of us practice what we call as narrative-based medicine, which is practically based on the experience, your own experience, experience of your seniors, your personal experiences, because if you had suffered that illness or that particular symptomatology, how you had, got treated yourself, and what was the outcome. So that is what we call as narrative-based medicine. However, to have our own narratives, we probably need to have at least close to 40 years of experience so that we could have seen all possible cases. All possible.
Very sorry for that, madam. Sorry.
No problem at all. So we could have seen all possible cases. Instead, what looks very difficult, but probably the more rational way is to practice evidence-based medicine, because there's already so much available in the literature regarding our problem which we are facing in clinic for a particular patient. So this is what most of us reads papers for, that we want to have evidence to treat our patients rightly in the clinics. And the important steps to practice evidence is to first have a question. So whatever information we require, we need to convert it into answerable questions. Look at the literature and track down all the possible, good evidence which is available to answer your question. And then the evidence which has come to you after searching the literature, you need to appraise that evidence critically and then implement the results from the evidence into our clinical practice. So this is what we do in evidence-based medicine. So therefore, doing critical appraisal of the published literature or evidence is the core aspect if we want to practice evidence-based medicine in the clinics. And that is what we are going to focus here today. So if you look at critical appraisal, it's not something which is random. It's a systematic process where you examine the research evidence for its validity, results, and relevance before you use it for making an informed decision. So two keywords here, one is validity and second is relevance. So validity means how true the results are. So meaning if you were to repeat the same study next time exactly in the same manner, whether you're going to get results which are similar to this. So that's where the validity comes from. And second is the relevance. So whatever you are seeing from the evidence, how relevant it is for your clinical practice. So how generalizable it is for your clinical practice, or what we call as, what is the clinical applicability of the entire evidence which you have just reviewed. So these two parameters we need to keep in mind whenever we are doing the appraisal of any published paper which we come across. Anyone who's interested, more to understand how to read a paper and what all goes into reading a paper, I must recommend this book, which is How to Read a Paper by Trisha Greenhalgh. This is now, when I read it, it was 3rd edition. Now you have 6th edition available. A interesting book to read, not boring at all, like most of us, fear about EBM. So this book makes the EBM interesting as well as, reading a paper interesting. So a must, if someone wants to read more and understand more, I seriously recommend to go through this book. Over and above, there are several checklists available for doing critical appraisal. So if you have an article in front of you, if you open any of these checklists, they give you an idea that what you need to look at and how you need to look at. And these are several checklists. You can pick up any one of them. They are pretty much very similar to each other. So these are the other resources which you can use if you want to do a critical appraisal of a paper yourself next time when you read it. We know that we come across several kinds of publications, some which report intervention, some which report diagnostics or screening tests, some which are talking about systematic reviews or meta-analysis, others on guidelines, cost effectiveness analysis, qualitative research, and questionnaire research. And for each of this, the basic principle of appraising a paper critically remain the same. But what is important is that there are subtle differences between them. And each of these, particular kind of paper, you have checklists for each one of them. So depending on what paper you are looking at, you can look at the relevant checklist here. If you look at the structure of a paper anywhere, now most of the journals ask for a particular structured format in which you can submit a paper. So there is an introduction, section followed by methods, results, and discussion. Introduction pretty much talks about why the research has been done. Methods mean how they did it and how they analyzed the results. And the results is what they found during the entire study. And discussion is what do they feel regarding their own results, what the results mean in isolation as well as compared to what is the literature already available. So this is pretty much the structure of any paper which you come across nowadays in the journals. And what is very important is most of us tend to read abstract and decide whether we should go ahead and read the rest of the paper or not. What is recommended is that you need to read the method section first. And unless the method is robust and it's very clearly, explicitly mentioned there how they did the entire study and how they analyze the results, no matter how good your hypothesis is, why you are doing that research, no matter how statistically significant or clinically significant your results are, and how cost effective the entire thing is, it may have no meaning if they did not use good methodology. Yeah, so that's why before going on and reading the paper in the entire paper, it's very important to look at the method section and decide whether you want to proceed reading the entire paper or you just want to there. So instead of abstract, it's the methods which are most important. So let's say we look at our paper which we had circulated sometime back last week. So we have this patient in clinic who has muscle invasive bladder cancer who's been planned for surgery. The question from the resident is that since minimally invasive surgery is something which is, is really in thing, whether this patient should undergo a laparoscopic radical cystectomy or an open radical cystectomy. So that's the question from the resident. And that's where we formulated our, entire question for which we are going to search the evidence for. So our question is whether laparoscopic cystectomy is superior or similar to open radical cystectomy in treatment of muscle invasive bladder cancer. And with that, we started searching the literature. And we came across, it's like a dream come true. You want to look at the evidence and you get a randomized control as your first item when you're looking at PubMed search. So we got this paper which was published in British Journal of Cancer in 2014, and which is the title says that it's a prospective randomized control trial of laparoscopic versus open radical cystectomy for bladder cancer. And they're looking at perioperative and oncologic outcomes with a 5-year follow-up. So looks like this paper is probably going to give us the answer. So let's see what exactly we did while we did the critical appraisal of paper. So the first thing which we wanted to look at is in the background, whether they have explicitly mentioned what is the research question, why have they done this particular study, and whether the study was original or not. And that's the most important thing whenever we are reading any paper, that we need to have our research question rightly mentioned there, because otherwise you would not be able to assess whether the methodology, whether the design of the study is appropriate to answer this research question or not. So most of the times in the introduction itself, you'll be able to find research question. If not, you may see it in the method section. Very rarely it does come up in the discussion section, which is, which looks little late, that looks more like an afterthought. The other thing which is very, very important is what is the reason why this research has been done. So they need to give, and third is whether the study was original or not. So whether we have for this particular study research question or not, so both the title as well as the introduction did mention the research question. And a good research question has 4 components. If you're talking about an interventional study, is one population, intervention, comparator, and outcome. And as you can see from the title, you do have your population, which is bladder cancer. We would have preferred if they had given whether it's a muscle invasive bladder cancer, but let's presume that since they're talking about cystectomy, that they're talking about muscle invasive bladder cancer. We have an intervention, which is laparoscopic radical cystectomy, and we have a comparator here, which is open radical cystectomy. And they are talking about outcomes in terms of perioperative and oncologic outcomes. So pretty much, it looks like that the research question is clearly answered here. Moving on to the next part, and Shubham, please let me know if someone wants to interrupt me in between and they want to take up questions in between. I can, take up the question.
Sure, madam. I
Otherwise
think,
we can.
yeah, I am the one who will be interrupting you the most. Don't worry.
Sure,
So,
sure. So,
yeah,
so
okay.
then I'm going. I'm not reading the chat box, and I'm just going
Yeah, yeah.
ahead.
Please go ahead. That's my job. I'll do that for you,
Sure,
ma'am. Don't
sure.
worry.
So if you look at this, the reasons what the authors presented in introduction for doing this study, they said there is, data coming up overall that the minimally invasive surgery is associated with lesser complication, lesser blood loss, shorter hospital stay. However, if you look at laparoscopic and open radical cystectomy, the data is limited to the retrospective comparative studies and the case studies and case series only, and which have their limitation in terms of significant selection bias. So that seems very reasonable that there is limited data and therefore there is need for this particular study. And then they formulated their question that they want to look at perioperative complications, ileal neobladder function, and medium-term survival of in a prospective randomized control trial comparing the two interventions.
So, ma'am, can we go back to the last slide?
Yes. Yeah.
So would the last paragraph summarize, would that be the aim of the study? Because I was looking through the methods again and I could not find a specific aim of the study. Because
Perfect. You're spot on, actually. So I was going to discuss that during the method section. So if you look at it here, they have talked about what their intervention, what their comparator is, but there is no one clear primary objective here to say what is their primary objective on the basis of which they have started the study. It's all over the place. They want to look at perioperative complication, they want to look at survival, they want to look at neobladder function, but they have not clearly spelled out what is their primary objective and what are their secondary objectives. So that's one of the major issues here in this particular study. So you are spot on there.
okay, ma'am, sure.
So the next question, whenever we read any study, we need to understand whether this study is original. So nobody really does, in practice. It's not that every day we have a Nobel Prize winning research, which is like never been done. And at the same time, it's never that somebody repeats exactly the same study and using the same methodology, same number of patients, same kind of population, and they repeat the entire thing altogether. Most of the times, it's like each study adds a little bit to what is already available in literature. It may be that the study may have more number of patients, may have longer follow-up, more rigorous methodology, better way of randomization, allocation concealment. They may be doing it in a different population. So each study, what it does, it contributes little bit towards when we want to synthesize the evidence, when you have multiple randomized control trial and you want to present it as meta-analysis. So many times these different trials have something different from the previous study and they contribute to the meta-analysis. So for this particular study, as the authors said that they don't have anything which is a randomized control trial, it seemed that this looks an original study. So it fulfills this particular criteria. Moving on to the methods, which is the most crucial part, as I said, whenever we are appraising any published paper. So the first thing which you need to ask is this study is about whom. So who are the patients who are part of the study? How did they recruit these participants in the study? Whom they included, whom they excluded from the study, and whether the subjects were studied in the real life circumstances. So that's the question. And what it decides that, how you did the recruitment, what your inclusion and exclusion criteria are, affects both the validity as well as generalizability. Typically in clinical trials, more so in trials, what happens that you include patients who are rarely fit. You typically take patients who have performance status 0 or 1, who have good organ functions, who are able to comply with all your study-related protocol. They don't have much comorbidity. So you practically take the most fit patients, and therefore they do well, they tolerate even the intensive treatment well, and their outcomes are much better. So if you see the similar situation in the clinic, it's these patients, these kind of fit patients probably form less than 50% of the people who walk into your clinic with that particular condition. So the results may not be applicable to all the patients with that particular disease condition, and therefore the study will not have generalizability. In this particular study, if you talk about they recruited patients from single center, which looks okay. What is not clearly mentioned, whether they recruited patients, all the consecutive patients who walked into their clinics, whether they screened all of them and they recruited from that screening lot, or whether there was some kind of a selection earlier on and only few of these patients were screened for the study and enrolled. Another important thing when you look at these studies is whether they have been done, what is the kind of setup where they have been done. Whether you already have good expertise and therefore the possibility is that you will have lesser complication rates and you have more complex cases coming to these setups. So again, you may not have a significant generalizability of these results. Same way, many times we follow these clinical trial patients much more stringently. They all have our phone numbers. They, if they have any problem, they are admitted very quickly and they're observed, monitored, their nutrition and everything is taken care of, which may not happen in the real life scenario. So all this, when we are reading the study, has to be taken into account, whether the results are going to be generalizable and whether we are going to see the same result if we try and replicate the same study intervention in our day-to-day practice. So let's come to the present study and look at the inclusion criteria. So the study included muscle invasive bladder cancer with T2 to T4A stage, T stage and N0NX, high risk and recurrent non-muscle invasive tumors, T1G3 tumors, extensive non-muscle invasive disease, which could not be controlled by TURBT and intravesical therapy. So it looks pretty much, that they have covered most of the, muscle invasive bladder cancer or candidates who are eligible for cystectomy. They have practically included all of them. This is what it looks like from the inclusion criteria. In exclusion criteria, they said the patient who decided not to participate and if there was any contraindication to radical cystectomy, including an ASA of more than 3, and if there were any contraindication for the neobladder. If you look at it in one go, it looks like that this is pretty much acceptable. But few things are missing here. You're talking about laparoscopic surgery. You have said that ASA more than 3. What about those who are morbidly obese? Did you include them or did you exclude them from this study is not very clear. Patients who received neoadjuvant chemotherapy, whether they were included, they were eligible for this study or not, or whether they were excluded from the study is not very clear. Patients who have had surgery earlier, where doing a laparoscopic surgery may become a little difficult later on if they had abdominal surgeries, whether they were included or not, is not clear from the inclusion criteria. However, when you look at the characteristics of patients, they do say that patients who had, there were few patients who had earlier surgery were included in the present trial. So these are the things which we need to keep in mind. So when we are looking at this inclusion criteria and exclusion criteria, it looks pretty inclusive. It looks like it fulfills most of our requirement when we talk about such patients coming to the clinic. But still, there are certain misses, and we are not clear whether they have included those patients or excluded those patients.
Question, madam.
Yeah.
So what about just the last slide again? Sorry.
Yeah.
So what about the age? Most of the most of the publication, the dissertations that we write, the first criteria is the age should be between this and this, which I felt was missing in this thing. So is that a must, or we can?
No, it's very important, and I was going to come to it when they were talking about how they stratified the patient. They had one of the stratification factor as age, and here there is no mention of age. So it's very, very important to mention from which age group to which age group they included the patient, because if you look at the baseline characteristics, they've given the mean age with the standard deviation, and they've said that it's around in 60s. Yes. But we are not clear whether they have patients who were younger also, meaning they did not give even the range of age range which they included in the study. So that's something which is a problem here, that they did not mention what's the age which was considered as an inclusion. Typically, what we write in any adult trial is more than 80 years. And some people do exclude elderly, above 70 years, because then it becomes difficult to, give interventions which are more intensive, and they, experience more toxicity. But here they did not mention that. But in one of the stratification factors, they've written that age was the stratification factor. And that's very difficult to figure out because there is nowhere other than that baseline characteristics table mention of any age group.
Okay, ma'am. Also, they did not mention about a time interval in which they accrued the patients actually. So, will that be a part? It's not a part of patient selection, but it's a part of the methodology, I think.
Sure. So they actually typically, when they write time period for selection, they typically write in the results section. And in this study, the inclusion, the time period where they accrued patient was from 2008 to 2012,
they've mentioned
January. And February 2013, they made a call for follow-up, and that was probably their end of study as far as for this particular paper. So that was given in the results.
Okay, thank you, ma'am.
Manju, if I can just come in, there is a question on the chat which says that performance status has not been accounted for in the inclusion criteria.
Yeah, so I agree with that point that performance status has not been accounted for. But what I felt that they probably kept ASA here instead of performance status, and they used it more as a surrogate for the performance status. But absolutely right that for majority of the oncology trials, and especially when we talk about interventional studies, they definitely mention performance status.
Sure, ma'am.
Yeah. Okay. So the next question, which should come in our mind when we are talking about a study, whether the study design is sensible or not, whether they have they're talking about specific intervention or other maneuver, and whether against what they're comparing it with. So if you look at from that perspective, they were very clear that they're talking about laparoscopic radical cystectomy as the intervention, and the comparator is open radical cystectomy. What they're talking here is non-inferiority design, randomized control trial. So if you read this line, it looks perfect that we are going to get all our answers. But as we'll proceed with subsequent slides, we'll realize that there are several problems when they're talking about this particular study design and how they have included, how they have calculated the sample size and the non-inferiority margin. So we'll talk about that in a bit. So, but till here, it looks that, the study design is going to give us the answer, what we are looking at, what our research question was. So the study design is going to give an answer for. So that's another thing. We need to match study design research question and understand whether it's going to give the answer for that research question, which we have asked for. Another important thing is the outcomes which they have decided to measure, whether they are really measurable and valid or not. So if you look at drug trials, typically, or any other oncology trial, the hardest endpoint is death. And when we talk about overall survival, and it's measurable, it's valid, nobody can change that. But there are certain other outcomes, like if you're looking at how a person is feeling, if you're talking in terms of pain, if you're looking at, time to discharge, analgesic requirement. So all these things are, you need to use tools which are validated. You need to use the same outcome measures which have been used in other studies, have been validated. So the entire idea is that your outcome measure should measure what it is supposed to measure. And it is, whether anyone who measures it, there shouldn't be a variation. So that's something which is very, very important when we are talking about outcome measures. And the problem is not only just, these soft endpoints. Sometimes the problem happens when we talk about even progression-free survival in oncology setting. And many times, you find a difference that if you have a trial, which is a drug trial looking at progression-free survival, you have an oncologist assessing the progression versus an independent review committee assessing progression, and you always find a difference between the progression-free survival. So something which may look really measurable, that you will say, okay, disease progression will be measured like this, still can have variation if you know what you are handling versus an independent blinded review committee. So that's something which is very, very important when we talk about outcome measures. So let's look at what this study measured. So what outcomes were measured and how did they measure it? So if you look at it, they had several outcomes. They had perioperative outcomes, which included operative time, estimated blood loss, analgesic requirement, time to resumption of oral intake, postoperative length of stay, complication rates. And all surgical complications, they said they measured as, Cleveland classification system. neobladder functional outcomes they measured. They measured the oncologic outcomes like lymph node yield, positive surgical margin rate, recurrence-free survival, and overall survival. What they have not defined here is, definition of each one of these. So, when you say that analgesic time to resumption of oral intake, post-operative length of stay, how you are going to define from which time point to which time point. Same way, how did they define the recurrence-free survival is all not explicitly mentioned when they are talking about these outcomes. Another problem is, as we discussed some time back, there is not one primary outcome. There are just multiple outcomes, and we don't know which one is the primary outcome in this study. To interpret the results and say that whether laparoscopic surgery is better than the open radical cystectomy with respect to what, we don't have one primary outcome here. So there is multiplicity here of variables, and you will see the problem which can come when you're analyzing multiple variables. I'm sure Priya must have covered in our earlier talks, but just, we'll see what all issues can come in. Another very important thing is that we need to look at the entire study and see whether the systematic biases have been avoided or minimized or not. So bias can come at several levels. So you can have bias at the time of randomization, though we feel that randomization should take care of all the inherent biases or differences between the group. But there are problems with randomization which can create bias at the time of recruitment or at the time of selection. Then you have bias in terms of how you perform interventions or how you perform an intervention between the control group and the intervention group. So there can be performance bias, and we'll take examples of each when we are talking about this particular study. Then there can be exclusion bias. So there is a possibility that you do not follow up all the patients similarly. There are few patients from the intervention arm may drop off early for various reasons, and they may be just not accounted for in the analysis. And that may bias your results. So somebody, if you're running a drug trial and if you have chemotoxicity, and if you have one person who drops off because of chemotoxicity without disease progression, you will censor that person at that particular time point. And you will have, it may be because of the disease progression that he was experiencing more chemotoxicity, but it's just that you have not documented that disease progression and you have taken off that poor performer from your group, and that will bias the results. So there can be exclusion bias as you follow up these patients. There can be detection bias. So the person who's assessing the outcome, if he or she knows which arm the patient belongs to, there is a possibility that there may be a detection bias which can come in. So let's say if you're running an antihypertensive trial and you already know that the person is on a new antihypertensive arm, and if you record a reading, let's say 24 hours after the antihypertensive and the blood pressure is still slightly on the higher side, there may be a tendency for that person who's the assessor to record the blood pressure again after some time, which may drop down because he or she feels that this new antihypertensive should work. And that itself can introduce bias because you have two different readings which are different, and you choose to write down the reading which is on the lower side. So these are the components which can bring in the detection bias. So let's see in our particular study where all the bias could come in from. So let's look at how did they randomize. So
can I interrupt? Can I interrupt? There's a question on the endpoints only. So Dr. Randeep is asking, does it make a difference if we have a single primary endpoint versus having co-primary endpoints? And and also about the hierarchical testing for endpoint, does hierarchical testing reduce the validity?
So if you look at it's better we study ourselves to have single primary endpoint. There are studies which talk about co-primary endpoint, but when we analyze when we decide co-primary endpoint, it's very important that both of them should have equal relevance, and you should be able to document them very clearly. So just to give you an example, and if you're talking about, let's say, trials which are looking at coronary artery disease, and your endpoint can be sudden cardiac death, your endpoint could be unstable angina, your endpoint could be, which you're talking about as the need for or escalation in terms of the additional medical management. So these all can, come in as your endpoint, and they all can be part of your what we call as co-primary endpoint. The question is sudden cardiac death, or your need for change in the medical management is as bad as sudden cardiac death? Answer is no. So if you require slight, modification in the medical management for that patient to make him a little more stable, it's not, that relevant as if you were able to reduce the sudden cardiac death. So if you combine these two entities and you analyze the result, you may have a chance that the intervention has not reduced much the sudden cardiac death, but has only changed, the need for change in medical management. Are you going to interpret both the intervention and comparative, where one has made remarkable difference in the sudden cardiac death versus the other, where the entire co-primary endpoint was changed just because, or composite endpoint was changed because of the change in the need for medical management? So we need to be very careful when we are selecting co-primary endpoint. You need to have your study which is powered enough to detect difference between both these, co-primary. If you're talking about co-primary endpoint, you should be able to detect the difference between both. You should have adequate power for that. So that's something which is important. Yeah.
Ma'am, a word about the hierarchical testing for endpoints.
So Priya, do you want to take up, or should I? Hello?
So typically hierarchical testing is done. One example of hierarchical testing is when you do multiple interim analysis. There, the alpha, the type 1 error gets adjusted so that the overall type 1 error remains constant and your chances of a false positive are reduced. Sometimes you may have multiple primary endpoints. Now, that is not the same as having co-primary endpoints. You could have multiple primary endpoints where if any one of the endpoints becomes statistically significant, you would consider the study to be significant. There, again, the overall type 1 error, which we spoke about, the alpha error, is adjusted so that your overall risk of a false positive is minimized. On the other hand, when you have co-primary endpoints, each endpoint is tested at a 5% type 1 error. And both your endpoints will have to be significant for the study to be considered a significant study, for the intervention to be considered significant. So that's the difference over there.
Okay, ma'am. Okay. There's one more comment that what you said about the outcomes being defined. They've also not given the definition. Dr. Manish Jethani has commented that they've not given the definition of recurrence-free survival or the OS.
Correct. So that's what I said. They have not defined how, meaning how the RFS was defined in the study, how the OS was defined in the study. How did they, decide on the analgesic requirement? Was there any, pain scale was used to define the, extent of pain, and then based on that, the analgesic requirement was, assessed. So all that is not clear in the article.
Sure, ma'am.
So coming on to the randomization, so this was a single center study, and as I said, that they have not clearly mentioned whether they, assessed, screened each of the consecutive patients who came with muscle-invasive bladder cancer in their study to be enrolled and randomized. So here they say that randomization was done 1:1 at the time of pre-operative assessment to receive either laparoscopic or open surgery at the time of pre-operative assessment. Again, here it's not clear who decided at this time who screened the patient, whether it was the surgeon who did the surgery subsequently, who did the preoperative assessment and decided whether this patient is fulfilling all the screening criteria and can be considered for randomization. So again, a source of bias which can come in. The second thing was that the random numbers were generated by a statistician. And as I was telling you earlier, that they said they stratified according to the sex, age, and clinical stage. But here again, there is no distinction given that what age group was considered, or what age cutoff was considered for the stratification. And same way for clinical stage. But when you read the results, it appears that they practically took the T stage, each T stage as the stratification factor. Looking at the numbers, the total numbers which you have in the study, and if you look at these number of stratification factors, it's a little difficult to use so many stratification factors with such a small number of or such a small sample size. The other problem is there is no so it's like the person who was doing the surgery, whether he's, as I said earlier, whether he's the same person who's, done the screening assessment and decided whether this person is fit enough for inclusion in the study and then subsequent randomization. So I'll come on to that in a bit, when you look at this problem and whether this really affected the inclusion of the patient in the study. Another important thing is here that all surgeries were performed by a single surgeon. Though it may look like that, it's the same surgeon who's doing the open radical cystectomy and laparoscopic radical cystectomy. So it's a good, you have the same kind of expertise. And this was a person who was already experienced in more than 100 cases of laparoscopic surgery, as well as prior experience in open radical cystectomy. But as there is no blinding feasible here, if you have a same surgeon performing and if he or she has more, sort of inclination towards one kind of a surgery, there is a higher chance that there may be differences just because of this performance by a single person in terms of the outcomes which you are going to assess. Not in terms of oncological outcomes, but the soft outcomes may have differences just because of this particular bias which can come in. So if you look at this, there were 388 bladder cancer patients in total, out of which they excluded 315 patients. So I can understand that they excluded the non-muscle invasive bladder cancer, but what is worrisome, if you exclude these 228, you are left with some 160 odd patients, out of which 50 refused randomization, which is a little surprising. So I don't, we don't know what's the reason, whether it's the way they were counseled or whether they were really not fulfilling the other criteria for undergoing the laparoscopic radical cystectomy, and that's the reason why the counseling happened and they refused the randomization, and did not agree for going into either arm. So that's almost 1/3 people refused the randomization, and which indicates that there was either a bias in terms of person who's counseling, that he felt that this person is probably a better candidate for laparoscopic or open radical cystectomy, and let's not take that person into the study. So as a result, 73 patients were randomized. So a significant number excluded. So there is a problem in terms of selection. If you look at here, they said they stratified as per stage, which is clear from here that they stratified as per T stage. Majority of cases, the inclusion criteria were really wide. They were supposed to include till T4A patients, but here, if you look at, the majority of patients had T2 disease. So again, clearly indicating that patients who had little more advanced disease were probably not either screened for trial, or this is a center which does not see, T4 disease. So these are the two reasons. So again, whatever the results will come out from this study will probably be applicable to more of T2 and T3 disease, not so much for the T4 disease. If you look at the rest of the consort diagram, so 36 out of the patients who were randomized, 36 underwent laparoscopic surgery, 37 open, and ultimately 35 in each arm were eligible for analysis. So this is what we were talking about in terms of performance bias. And the next thing which was there in terms of outcome detection was the detection bias. So whether the assessment was blind or not. So as I said, it was same surgeon. And one of the outcomes was lymph node yield. So it's the surgeon as well as the pathologist. If they are not, surgeon is definitely not blinded. And if the pathologist is also not blinded, it's going to affect, how we are going to look at the lymph node yield, and it can favor any arm if they are aware of what is, which arm the patient is coming to. Same way, most of the peri-operative outcomes, again, there is no mention of whether it was a blinded assessment or not. So if I'm a good laparoscopic surgeon, I'm not, I'm a medical oncologist, no connection with surgery, but just if I want to say that, laparoscopic surgery does best, I may discharge my patient a day earlier, and it's just a day difference, which can make it look like that laparoscopic radical cystectomy is better as compared to open radical cystectomy as with respect to the length of hospitalization. Again, analgesic requirement, it will vary that what exactly is the threshold for the person who is looking in the post-operative period in terms of using analgesic, stepping up analgesic. So all that is going to be affecting the results, many of these outcomes which the trial was assessing, and that can contribute to the problems if it is not a blinded assessment. The next part is that we need to look at the sample size, whether all the preliminary statistical questions were addressed appropriately or not. And when we say sample size calculation, it should be based around one primary objective and primary endpoint. And we should be looking at a clinically significant effect. If you look at this study, how they calculate the sample size, as they said, it was a single center, randomized non-inferiority study. And now you look at it, they say the primary endpoint by which the sample size was determined was lymph node yield. Assuming the mean difference of lymph node yield between the two groups was 2 with a standard deviation of 4, a loss to follow-up proportion of 5%, power of 80% at a significance level of 5%, 70 patients to be enrolled in this particular study. Big problem here. We all know there is, lymph node yield is something which I won't really put it as clinically significant. Second, there isn't much difference in terms of lymph node yield if you talk about between the laparoscopic and open radical cystectomy. And this is not my opinion. This is the opinion of the uro-oncologist whom I spoke to. And the third thing is it all depends on, what's the expertise of the person who's doing the surgery in terms of laparoscopic surgery. So they may be able to dissect much more. So this is a soft endpoint, not clinically relevant, not even sure that whether it has any oncological relevance. And that was the one on which they, based the primary endpoint. On this primary endpoint, they based the sample size calculation. And if you look at it, they have said that the mean difference between the two would be, two groups would be 2 with a standard deviation of 4. So according to me, maybe Priya can comment later, but this is something which is not acceptable in terms of how you would calculate a sample size. It typically says that you found out probably what is the endpoint which is going to give you the least numbers, and that's what you selected for sample size calculation. Coming on to the results.
So, ma'am, can I get actually Dr. Priya right now into the statistical part of it? Yeah, because I think this is what we have been doing it for the past 3 weeks. That, ma'am, when we talk about the standard, mean difference in the standard deviation, this would mean that we would accept patients who also have, because having a mean difference of 2 with a standard deviation of 4 would make it anything between -2 and +6. So I don't get this part actually, that how can the standard deviation be 4 with the mean difference being just 2?
Yeah, so what they've said is that the difference between the mean yield between the two groups could be 2 with a standard deviation of 4. So you're absolutely right. This is a two-sided test where you're allowing for one group to have a higher yield or a lower yield as compared to the other group. Okay. As Manju has very rightly pointed out, this is not the correct way of calculating a sample size, because we're not sure what the primary outcome was, and it appears now that they looked at different outcomes and then found the outcome which gave them the least sample size. This is definitely not an outcome which is clinically very important or relevant. Also, when we talk about non-inferiority studies, and I don't think we've covered that in detail in the research methods part of it, but we are typically interested in showing that a new intervention is not grossly inferior to the existing standard, but offers some other advantages. Okay, so a classic example would be, is 2-drug chemotherapy non-inferior to 3-drug? What we mean by that is maybe the reduction in survival is not much, but it has less toxicity, better compliance, cheaper, whatever. And for these kinds of studies, you need to be very careful about what an inferiority margin is. So how much would you consider inferior, and therefore how much would you consider non-inferior? So on one hand, they call this a non-inferiority study, but the sample size that they've calculated is a classic superiority study. And the reason for this is, when we talk about non-inferiority trials, our margin of inferiority is usually very, very small. Remember, we spoke about alpha, beta, and delta. Delta is the margin of difference that you expect between two treatments. So if I'm trying to show that a new treatment is non-inferior to an existing treatment, I will accept only a very small margin of inferiority. And we've discussed how sample size is inversely proportional to the margin of difference. So in non-inferiority trials, typically will have very, very large sample sizes, which is possibly one reason why they have decided not to calculate sample size in the true non-inferior study, and I've just done some hodgepodge and given us a sample size over here.
Okay, ma'am. Ma'am, we can continue now. Thank you.
Yeah, thank you. Thanks, Priya. So the next thing which we need to look at once we have finished looking at the sample size, look at study design, is the results. And when they present results, we need to look at, so though randomization is supposed to take care of any differences or make the group look very similar to each other, but still there can be some variables which can be imbalanced between the two groups if you randomize patients. And typically what is done is that you analyze the results by adjusting these baseline differences between different variables and see whether your results do not change as opposed to your unadjusted analysis. So then you can say that probably this variable did not affect the overall outcome much. And the next thing which you need to look at in the results, whether the appropriate statistical tests were used or not, or if they have started using some obscure statistical tests. So most of these studies use the well-known statistical tests which Priya must have spoken about when they compare two groups. But if you start finding that there are some obscure test results or there is some different definition how they have decided a particular endpoint, that's where you should start getting suspicious and look at these things more carefully. So not really obscure statistical tests, but since we were talking about obscure and we were talking about how we define endpoint, a very interesting example is one of these studies which evaluated a new drug in Hodgkin's lymphoma. And instead of using progression-free survival, they changed it to modified progression-free survival. And the modification was that if a physician felt that the patient is not responding at the end of 2 cycles of chemotherapy based on the PET scan, the therapy could be changed. And this was considered as one of the progression event. And this was the one which clearly skewed the results towards the newer therapy. So in an unblinded study, if you have these kind of endpoints, or if you're using some, really different statistical tests which you have not heard of earlier, it's good to Google and see whether there is anything which is missing here, or any more adjustments are being done to just show that the results are different or they are meaningful. Another very important point is that you need to have the original study protocol, and most of the good journals, make it a point that you submit the original protocol, so that you need to see whether the data analysis is as per the original study protocol. If you don't have the protocol, at least the methodology section tells that how the data will be analyzed, who will be included in the efficacy analysis, who would be included in the toxicity analysis if we are talking in terms of the drug trials. If you're talking whether it was intention to treat analysis or not, all the patients who were randomized, whether all of them were accounted for the analysis as per the arm to which they were randomized. Another important thing is statistical significance versus clinical significance. We are all fascinated by p-values, but we need to look at whatever difference has been shown, whether it has any clinical meaning to the patient if we start using these interventions in our clinic. So let's move to the results of statistics which they used in the study. So pretty much they said that they use intention to treat analysis, which is fair, but it's very important that if they have written intention to treat analysis, you should see whether they have really analyzed the patients as per the group to which they were assigned or randomized to. Because sometimes it's just a writing, not usually in good journals, but you do have this tendency from people that they write intention to treat analysis where it wasn't an intention to treat analysis. So it's very, very important to pay attention to that. Rest, they said they compared variables, continuous variables using the student t-test or the Mann-Whitney test or Mann-Whitney u-test as appropriate, and survival curve using the Kaplan-Meier method. Differences between the survival using the log rank and the multivariate analysis was done using the Cox regression analysis. Here, again, they come back to the age factor, they come back to the lymph node status, and now they come back to tumor PT stage. If you look at the initial stratification which they did, it was done based on the T stage, the clinical T stage, and here they are talking about tumor PT stage. Another thing, they said that all p-values were two-sided and p less than 0.05 was considered significant. So this is pretty much the there are a few important things which are not very clear here in the protocol, and they have changed how they have planned to analyze the results. Coming on to the results, if you look at the baseline characteristics, as Shubham had pointed out very clearly that there was no age range given, and what they talk about is mean age with the standard deviation. So it does look like that there was a very narrow range of patients who were taken into this study. So majority were elderly, but it's nowhere clearly written that this is the subgroup. We can say that this is the age group where you see most of the bladder cancer, but it's not that. Bladder cancer does not happen in somebody who's young or older than this. So you need to be explicit when you are talking about your methodology, what age group you are going to include. If you look at it, they had stratification based on male and female, very few female patients, and but they are well balanced because they said it was stratification. What is striking here when you look at the results at the BMI, the mean BMI was 22. So though they did not say anywhere that they are going to exclude the people who are morbidly obese or obese, but if you look at this BMI, it looks like really fit and lean people who were included in this study. So again, indicates that unless that's the hospital which only sees lean people, this again indicates a bit of selection bias. They have not mentioned about exclusion or inclusion of previous abdominal surgery, but they have included it here. If you look at it, predominantly the patients were ASA2, and as we saw earlier from the consort diagram, majority had clinical T2. And there were some patients who had recurrent tumor after the TURBT or partial cystectomy. So again, it's not mentioned how many of them were after partial cystectomy and how many were after TURBT. If you look at the median follow-up, it's 26 months and 32 months. I'll come about regarding the follow-up. I'll talk about it in the later slides. And if you look at loss to follow-up, it's very similar. What is striking here is the comparison for all these variables, trying to look at statistical significance, which is absolutely not recommended for the simple reason that you are analyzing these many variables, and just by chance you may be able to find something which is statistically significant. So what actually, if you've done a randomized controlled trial, what you need to look at is just to eyeball these two columns and see whether they were matched or not, or whether you're seeing any striking difference between the two groups of individuals in two different arms. So that's something which is recommended, not the p-value, and I'm sure Priya would talk about it later, or if you want to explain here on this slide, because there are multiple other similar tables where we'll see where there are a lot of p-values coming in. But when we talk about baseline characteristics, it's not really recommended to do the statistical significance and look at the p-values.
Yeah. So if I can, sorry,
please,
I can just re-emphasize the baseline characteristics. One slide back, please. So in the class on p-values, we discussed what a p-value actually means, and the definition is that it tells you what is the probability that a difference that you're seeing has occurred just by chance. So when you're comparing baseline characteristics, any difference that you see has to have occurred only by chance, right? Because these are the baseline characteristics. These are not the final results of the intervention. If you have randomized properly, then any difference that has occurred between the groups has to have occurred only by chance, and that it makes no sense to have a p-value associated with it. So if you read the consort guidelines for reporting of clinical trials, whether they're superiority or non-inferiority, there is absolutely no need to include a p-value. You should not be including a p-value. Instead, as Manju has already said, you just describe the characteristics of the groups and eyeball the data to see whether a particular characteristic is grossly different between the two groups and needs to be taken into account while interpreting the results. And if you want to do that, you could do a subgroup analysis or include that variable in your regression model, which will adjust for any such differences. Thanks, Manju.
Thanks, Priya. Moving on to the perioperative outcomes. And again, you can see that the number of outcomes which they have analyzed and presented as mean and standard deviation. So according to them, operative time was statistically significantly different between laparoscopic. It was longer as compared to open. Similarly, if you look at the estimated blood loss, the number of blood transfusion, the analgesic requirement, oral intake, reduction of oral intake, all was statistically significant between the two and favoring the laparoscopic radical cystectomy, except the operative time. The post-operative length of stay was not different. What I want, and maybe even Priya can highlight, is just if you look at these values and if you look at these mean and standard deviation, they all look statistically significant here with very low p values. What is important, if you look at the overlap which you see, so if you look at the difference between these two groups, and if you look at the mean along with the standard deviation added to it, there isn't much difference between the two arms. So again, it brings me to the question regarding the significance of these values, clinical significance of these values, even though the p-values are really different, really significant, and they're really small. Priya, if you want to add anything here.
Yeah, so typically time, whether it's length of hospital stay, operative time, typically these are not going to be normally distributed. Okay? This kind of data is usually skewed, and it's a bit surprising that they've used the students t-test for this kind of data, because what would happen is most of your patients would have a certain operative time, but then you would have a few complicated cases which would have a prolonged time. Similarly, most of your patients would have a sort of standard hospital stay, but a few patients would have complications and stay longer. And this kind of data will be skewed and is best represented with medians, interquartile ranges. Also, as Manju has very rightly pointed out, when, suppose let's look at length of stay, you say that the mean is 15 plus minus 5, and we know that 95% of this data set will lie between the mean and two standard deviations on either side, which means most of the patients in this group, the lap group, would have had a stay between 15 plus minus 10 days, right? Which is 5 days to 25 days. And here it's 16 plus minus 12 days, which is absolutely the same thing, right? So here, fortunately for length of stay, the difference is not significant, but the same thing applies to operative time also. If you were to calculate the actual distribution of data based on mean plus two standard deviations, you would realize that there would be a lot of overlap, and it's probably a few skewed cases which are driving this so-called significant p-value. We have also spoken about confidence intervals in a previous class, where we decided that discuss that it's not just p-values which need to be reported, but you also need to report the difference along with confidence intervals for that difference, so that when you translate the results of this study to the population, you will know what range of values need to be expected. And obviously they have not done that, so it's inadequate reporting of results.
So similarly, if you look at the surgical complications, so they have clubbed it into different grades, and they say that there is not much difference. Whereas, if you look at between the two arms, if you look at the numbers here, if you look at blood transfusion, it was quite significant in open radical cystectomy arm as compared to laparoscopic radical cystectomy. So that's something which is striking. But if you look at overall, there isn't any difference between the grade 2, grade 3A and 3B complications. Coming on to the pathological outcomes and the sites of meds which they looked at. So if you look at the lymph node yield, as expected, this was not something which is a surprise, that there is not much difference between the lymph node yield and the two arms. The positive margin was seen in the open radical cystectomy arm as opposed to the laparoscopic radical cystectomy, but it was just one patient. What I want to highlight here is that if you look at it now, there were very few, as we said, very few people who had PT3 disease. Most of them had P2 disease, so really favorable set of patients. If you look at open radical cystectomy arm, and this is the group where you had PT3B more. So though the numbers are very small, you can't read more into it, but this is something which we need to keep in our mind when we are interpreting these results, that probably those who underwent open radical cystectomy had higher stage of disease, and that probably is the reason for getting this positive surgical margin and not so much in the laparoscopic radical cystectomy, and that's probably the reason for not getting these positive margins. So we just need to again slight hint that it could be biased of individuals who were taken up for this particular study, and more so those who had undergone open radical cystectomy. Coming on to differences in terms of local recurrence and distant mets, there is again no difference, but very small numbers in each, because as such you have a denominator which was just 35 in each arm.
So, ma'am, just a question. So,
Yeah.
just the slide back, madam. So, they have mentioned the p-value for, no, ma'am, the next slide, please.
Sure.
Next.
Yeah. Is this
Yeah,
back?
this one. So, they have mentioned the p-value between PT1, the two arms, but why not between the PT2 arm? So,
this is what they have done overall. I don't think they have just looked at the PT1. This was an overall difference between the two, pathological stage, whether there is any difference between the two or not.
okay, so this was the overall, not specific to the PT1 stage, because the numbers are not that many to get anything.
If you look at numbers overall are too small to make any meaning out of p-value, but this was for total, not just for PT1.
And similarly, Shubham, the next one, the grade, it's for all the grades put together. It's not only for grade 1.
Okay.
Similarly, here for histologic type, it's for all the histological.
Correct.
Given you the breakdown, but they've done the overall calculation.
So again, they've compared the neobladder functional outcomes, and I'm not sure about the clinical meaning of this comparison, because as per my discussion, there is actually not much difference between if a neobladder after laparoscopic surgery or open radical cystectomy. So people feel that this comparison is not of much use if you're talking about approach towards radical cystectomy. Coming to the duration of follow-up, so if you remember the title, they talked about 5-year follow-up. If you look at the median follow-up here, it's 26, with the range being 4 to 59 months in the laparoscopic group, and same way 32 months in the open surgery group, with the range being 6 to 60. The study was conducted between 2008 and 2012. That was the time period for inclusion, and had follow-up till 2013. If you look at it, it only indicates probably majority of the patients either were included towards the later part of the study, because they said that the follow-up was till the last date, except for 3 patients, there was no loss to follow-up. So having this median follow-up and giving the 5-year survival data is not appropriate, though they have the range falls at 5 years, but this is not the median follow-up, which is 5 years, and therefore giving survival data or the oncologic outcome in terms of recurrence-free survival, or for that matter overall survival at 5 years, would be appropriate. So that's something which we need to keep in mind. And that we move projected here. Again, they have said that there is no difference between open and the laparoscopic radical cystectomy in terms of recurrence-free survival or overall survival. Between the lymph node positive and the lymph node negative patient, there is not much difference. The thing which is missing here is numbers at risk. So to interpret this data at 5 years, we don't have enough numbers who have followed up for this time period to compare actually the difference between the two. Having said that, it doesn't look like that there is a difference between the two if you look at these survival curves. Priya, you want to take up anything on the survival curves here?
Yeah, just a couple of things to add. So if you look at the curves, the first 2 curves in the top row, you can see that the curves are overlapping at multiple points, right? And when you have curves which overlap, they do not fulfill what we call the proportional hazard assumption, which is something we discussed in the lecture on survival analysis, that when we calculate a hazard ratio, we assume that though the actual risk of the event, which we call the hazard, changes with time, the ratio between the hazard in the treatment arm versus the control arm remains constant and remains proportional, which means one group always has a higher hazard as compared to the other group, and therefore we are able to average out and get a single hazard ratio. When you have curves which cut each other, which cross each other, it means that the hazard ratio is changing. Sometimes one group is doing better, at other times the other group is doing better, and you cannot average out and get a single ratio for these kind of curves. So the very use of hazard ratio for these kind of overlapping curves is wrong. I'm going to draw your attention to the graph at the bottom right, that is lymph node positive patients. Now, if you go back and read, I think they had a total of around 8 patients, Manju, if I'm not wrong.
Yeah.
Yeah. So when you have 8 patients,
I'm just coming back to that.
yeah. It is ridiculous to draw a Kaplan-Meier curve because even if one patient has an event or does not have an event, it changes the entire curve by 100 divided by 8 because there are only 8 in the denominator, right? Which is a 12 to 13% change. So with such low numbers, plotting a Kaplan-Meier curve is not a very good idea because even small changes in events exaggerate the step down in the curve, which are the events. Okay, so these were the two things that I wanted to point out. They have mentioned confidence intervals over here. Okay, 95% confidence intervals for each of the outcomes, which is a good thing. But again, it does not fit in with the concept of non-inferiority, which probably Manju will discuss later, or we can discuss at the end.
Sure. So this is going to be my last slide. So they did discuss a lot of these points, which we just talked about in the discussion towards the end of the discussion, that these were the limitations of study. But having said everything, at the end of the study, they said that laparoscopic radical cystectomy is superior to the open radical cystectomy. So they started to design a trial which was a non-inferiority trial, not appropriate in terms of sample size, the assumptions taken for sample size. And at the end of it, they have claimed superiority. And I'm sure none of you would agree with that. And as we said that, they did discuss limitations, some of which we discussed and some more which we have talked about and they have not spoken in the entire paper. So that was it from my side. Priya, you want to say anything? And otherwise, we'll go on to the conclusions.
No, I think we can go on to the conclusions unless there are questions. I think I've covered most of what I had planned to cover. But if there are...
So there's one comment from my side, madam, that when we look at the statistics part, especially the t-test and that thing, we actually don't pay much attention to it. And I don't think we are actually qualified to pay attention to it because we assume that if it's gone into a journal, a reputed journal, the editors must have gone through the tests which have been applied. Because really, even if I ask you to take a class for all of us for statistic tests, I don't think any of us would remember it to reapply it. So would it be fair to say that we should go with the tests that have been applied because that's what we do actually?
So as Manju very rightly said, there are pretty standard tests which need to be used most of the time. So we know that for normally distributed data, we use an unpaired t-test or a student test. We know that for skewed data, we use a Mann-Whitney test. We know that for categorical data, we use a chi-square test, right? And as you start reading papers, you will realize that these kind of tests are very, very standard, and you will sort of pick up that these need to be done. Logistic regression needs to be done, okay? If you come across some totally obscure test or some long drawn explanation as to why a standard test was not used, then that should get your antennae up, and then you can either read up or ask a statistician about whether this was the appropriate thing to do. Most reputed journals now do have a statistical editor on board who will vet the article for its statistical content before publishing. But there are a lot of journals which still don't do that. And so you can't just take it as face value. You will have to sort of read a bit about the different tests.
Okay. So start reading it up. Don't skip that thing.
Yeah. There is a question about randomization bias again.
Sorry. I'll just stop sharing. So this is the last slide, and then maybe we'll just take the question. So I would want to emphasize that you need to focus on the method section. Having a randomized control trial and it being published in high impact journal does not mean that it is the best available evidence, and you need to appraise it critically, as this was a British Journal Cancer publication, a randomized control trial. So that's the reason for taking up this example. Very similar rules apply to the other kinds of studies, whether you're talking about systematic reviews or you're talking about cost-effective analysis or other quantitative or qualitative studies. So that's something which we need to keep in mind. Basic principles are same, but there are checklists which you can refer. So with that, I'll stop sharing and maybe we can take the question. Sorry.
So, ma'am, there was this question on the randomization bias. Can you
Correct.
explain the randomization bias? Dr. Kundu has asked, ma'am.
Correct. So the first thing is that, as you can clearly, if you remember the slide, we had close to 300 plus patients, and they said that 50 refused randomization. What is important here that, the randomization was being done at the time of pre-operative assessment. And if this pre-operative assessment, once you have all the information available, is being done by the same surgeon who is going to operate down the line, and if that surgeon looking at the patient, let's say this patient is morbidly obese or has had bad abdominal surgery, a big scar where you worry about adhesion, what you would do typically, you would exclude the patient, not even mention in the screening log. Or the other way is that you counsel the patient and you say that see, you have these issues. There is a risk that you may, if you try doing laparoscopic radical cystectomy, there may be a chance of little more complication as opposed to open radical cystectomy, and other way around. So if you feel that laparoscopic radical cystectomy is something which you want to do with a lean, fit patient, you may not want to randomize the patient into this particular trial. You will just do a laparoscopic radical cystectomy out of the trial. So there are problems when you have the same person who's going to do the assessment is going to be involved in the randomization. So a lot may get excluded at the level of screening even before they can come into the randomization. So the population which you have randomized is not really representative of your inclusion criteria, the broad inclusion criteria which you have included and mentioned in your study. And again, it's like it's the same person who's going to follow up, and you have no, even if the randomization sequence is given by the statistician, he or she knows the next person who's going to come on to the trial is sitting in front of me and he's not really looking very fit, and we know that the next thing is going into the laparoscopic radical cystectomy, and you're not happy looking at that patient for laparoscopic radical cystectomy, you would just not screen that patient. So these are the problems which can come up when you have you know the randomization sequence, and you are the person who's going to screen all the individuals.
And Manju, if I can just add, I don't know whether I might have missed it, whether you already covered it, that allocation concealment is not mentioned anywhere in this paper.
Right? Correct.
And that's something which is very, very important. So randomizing is one aspect where you randomly allocate patients to two arms using a computer generated sequence of numbers. But who does that randomization, and how do you prevent somebody from finding out which arm the next patient is likely to go to? So there are various steps in randomization. It's not just drawing up a computer generated sequence of numbers. You lay down very objective criteria for the screening and eligibility. Okay, instead of just saying poor performance status. What is poor performance status? Significant cardiorespiratory. What do you mean by that? Right? Lay down objective criteria. So on spirometry, what should the patient achieve? What should the ejection fraction be? Okay, what are the exact conditions that you're going to exclude? And then the list of randomization numbers should be with somebody who is unrelated to the trial. So that the minute you decide that this person is eligible for the trial, that person allocates the arm. And then there is no changing. So their bias during randomization goes out completely.
Okay, ma'am, there's one more question on the YouTube channel actually that, so this is a study with which has multiple endpoints and probably more than one would be the primary endpoint. So how would you define the ideal endpoint, and how would you use that to calculate the sample size? So what I think the question is that which endpoint would you choose to calculate the sample size for a study like this?
So if if you're talking about oncology setting, and if you're talking about a trial where you want to prove, superiority or some, intervention like this, you would typically look at an oncological outcome. Or second is that you would look at peri-operative outcomes, and you decide what will be one or two important peri-operative outcomes which will have a meaningful value if you want to take this up, this particular intervention into your clinic tomorrow. So it could be, length of stay, it could be, the intraoperative blood loss, any two, whichever you feel is the most clinically meaningful for both patients as well as from your resource point of view. If you had to admit these patients for longer period of time, then in that case that's not really right, because you have limited resources, limited number of beds. So whatever is most clinically meaningful for you, you would select one of them. If you want to have perioperative means many of these, then we probably consider making it as a composite endpoint if feasible. Again, you need to see whether it's feasible to club all these different parameters into one, and what meaning they will have if you club them together. So there is no single answer, but typically, if you're talking about an intervention, a new intervention, you talk about oncologic outcomes. So you could talk about recurrence-free survival or disease-free survival or overall survival. It all depends on what resources you have, how much time you have, how many patients you will be able to enroll, and what will be meaningful at the end of the day. If you spend 10 years of your life and you come out with a trial, and if it doesn't have, it's not going to change anything, then in that case it will be it will not be of any value.
Okay, and there's one more question, that should we be mentioning?
Shubham, I'm sorry, because this question is on outcomes and endpoints. I'm just going to share screen for 1 minute.
Yes, sure.
So we have a talk on the 7th of November on this exact topic, outcomes and endpoints in clinical trial. This is by Mark Boyes, who's a very senior world-renowned statistician. He's also faculty at a number of research methods workshops and a fantastic speaker. I'm sorry, the link for this is not ready yet, but if you would like to be informed about it, please drop us an email at this address, ncg.credo.vrb@tmc.gov.in.
So whenever the link is ready, madam will put the flyer in some common groups, and I'll be sharing it in the Cancer Academy groups that we have. We have 3 or 4 now WhatsApp groups. So I'll do that for anybody who's interested, and we'll do that. Thank you. So there's just one last question, I think, that should we be mentioning p-values for demographic data in non-randomized studies?
No, you should not be mentioning p-values for baseline characteristics for any studies. You should be eyeballing the data, and if anything you feel is looking different, irrespective of whether it's statistically significant or not, you include it in your regression analysis or final analysis.
But ma'am, does it not give us a idea whether the study is biased or not? I mean, it tells you that you had more older people in this subgroup versus the other group. So having a p-value which tells you that this was a significant difference will probably tell you whether the study was biased or not. I mean,
so this will bring us back to a comment which somebody had put on this chat. What happens when you have a finding which is statistically significant, which is not clinically significant?
yes, Dr.
Understand that p-values are a direct function of the number. If you study 2,000 or 10,000 patients, almost anything can be made to look significant. If you study 50 patients, even huge differences may not be significant. Okay, so if you look at baseline characteristics and you find that the mean age between two groups differed by maybe 2 years, it may be statistically significant, but in clinical practice, we know that 61 versus 63 makes no difference, right? Physiologically, they are the same. On the other hand, you may find an age difference or a stage difference, which is not statistically significant, but you know that it could impact outcomes. And therefore, please don't go based on p-values. Please don't even report those p-values. Eyeball the data. And if you think anything is raising a question of whether that is responsible for the different outcomes, then you need to include that in a regression analysis.
Okay. Thank you, ma'am. Dr. Urvashi Jain has raised her hand. Dr. Urvashi, I'm just making you a co-host so that you come in, you can ask something if something that you want to ask, or you can put it in the chat box. Why is there a echo? Okay, Dr. Urvashi. Scary echo. Okay. So she's sorry. Okay, so Dr. Urvashi is not around, or you can put your question in the chat box. So, is Dr. Geeta around? Dr. Geeta?
You've you've taken not all. I don't have any question to ask.
Okay, okay, no, no, no. So,
Thanks a lot. Thank you.
thank you, Dr. Geeta. So, I actually wanted to get in Dr. Geeta to also mention what she thought of the class, but I'm sure she's overwhelmed with emotions and cannot, is not, is not. But thank you, Dr.
Yeah.
So thank you, Manju ma'am, thank you, Priya ma'am. The more we hear of medical statistics, the more we want to hear them more. And again, now I have another two, three topics in my mind, which I will put to Dr. Priya, that should we be knowing more about them, and probably we'll have one more class with madam. But I think the 7th November class, and we are now having them very regularly, madam. Are we doing it every Saturday? Because I saw flyers for some more of these, the NCG event, the statistic based events. So this one is on 7th November. Is there a pattern to it, ma'am?
Yeah, so I'm trying to get it into a pattern of the first Saturday of every month, unless
Okay,
that
okay,
happens to be a major holiday either for us or for the international faculty. But I think we
okay,
will be able to sustain this at least for the next few months. So
okay,
first
okay.
Saturday of every month.
As long it's not a Wednesday, 8:30 p.m., madam, we are very happy to. So thank you, ma'am. Thank you, Dr. Priya and Dr. Manju. Thank you, Manju ma'am, for sparing
Thank you.
your valuable time and joining. And we'll trouble you again for a hemato-onc lecture, ma'am. We are still yet to start that series. Thank you so much, madam. Thank you, Priya ma'am. And the next lecture is going to be on SBRT for lung cancer, for early lung cancer. So it is going to only talk about the controversy about SBRT for lung cancer. Should we be offering lung cancer, SBRT for all lung cancer patients, early lung cancer patients? Can it replace surgery? And we will have Dr. Anil Tipdewal again from Tata Memorial, who will tell us about the evidence and what we all need to know about SBRT. So we'll be joining at 8:30 next week, and next time we'll have definitely have a quiz ready for you. So thank you so much, and good night, and
Good
see you
night.
next Wednesday. Thank you, madam.
Thank you.
Thank you.
Thank you.